Hello there, my name is Fraz Hussain. I'm an orthopaedic consultant and specialist in knee and shoulder surgery here at the Royal Orthopaedic Hospital. What we're doing here is a demonstration of a knee examination aimed towards medical students to help them through their OSCE exams. So we have a patient here who we're going to be demonstrating on. This is Uzo. First stage of any examination is always introducing yourself to the patient and asking permission if you can examine them. So, hi, I'm Fraz. Do you mind if I examine you? Is that okay? All right, so we're just going to sanitize our hands. First thing we're going to do is look at Uzo's legs. So any part of a joint examination is divided into look, feel, move, and then your special test. So we're looking first of all. So what we're looking at is the overall alignment of Uzo's legs to see if they're in valgus or varus. You can comment on his feet, and he's slightly pronated with his feet with quite shallow arches. We're going to look from the side. Can I get you to turn that way? And we're looking for any hyperextension and the overall position. Looking at his muscle bulk, how good are his quads, his calves and his hamstrings. Get you to turn and face the wall now. And you're looking from around the back. And you're looking for any fullness in the popliteal fossas. Looking at the heel position. And Uzo's fairly neutral with his heels. Slightly pronated with his feet, but has a good knee position. Get you to turn around again, please. Look quite closely at the front of the knees, looking for any previous scars, any evidence of any previous surgery. So now we're going to ask Uzo to walk. So I'll get you to walk up towards the camera, and what I'm looking at is the gait cycle and just seeing where his initial contact is. Get you to walk back again, just keep walking up and down, looking to see how he pushes off. And as you're looking directly from behind, what I'm looking for is any varus thrusts as the knee goes into varus as his weight bearing, but he has a normal gait. Carry on. You can look for any antalgic gait with a reduction in the weight bearing part of the gait cycle. Thank you. So now we're going to get Uzo to lie down. We do a more focused examination of his knee. So again, I'm looking for any scars, any swelling. I'll look at the quads bulk, make sure that he's got no quadriceps wasting. So we've done our look. We're then going to feel. The first thing I do is just to feel the temperature between the two. And you're feeling for any warmth coming off the knee. And feel for an effusion. Now, with this one, what I'm doing is emptying the fluid out of the medial gutter and sweeping it across from one side to the other. You can sweep it down from the suprapatellar pouch into the medial gutter to see if he's got any fluid inside the knee, and he's got no fluid in there. Patellar taps can be useful, but you have to have a very large effusion for a patellar tap to be positive. So I'm sweeping the fluid down again and pressing down the top of the patella. Whenever you're doing any examination, make sure that you ask the patient, if I'm causing them any pain, please do tell me and I will stop. Feeling. You can feel around the top of the patella, around the patella itself, or over the patellar tendon down to the tuberosity. Now, feeling the joint lines, we have to bend the knee, and we bend it to about 90 degrees, and you can feel along the IT band, down to Gerdy's tubercle, and you can feel along the joint margins. I tend to feel along the lateral joint margin here to see if that's causing them any tenderness. You can feel the medial joint margin, and you can also feel over the femoral condyle to see if that causes them any discomfort. You can feel around the popliteal fossa to see if that causes any pain as well. And along the patellar tendon down to the tuberosity. So you've done your feel. Now we're going to get him to move. So active and passive. So first of all, active testing. Now Uzo, can I get you to bend your knee up as far as you can go? And just rest your foot down. Do the same on this side. And we're seeing how far he bends both his knees actively. So he's pretty good. He's got up to about 130. An extension, we're going to ask him to push his knees down into the bed and just check that he's got full extension on both sides. Now, patients may have an extensor lag, which means that they lack the power to fully extend their knees, which is a sign of quadriceps weakness. And what we can do here is just bend the knee slightly, support the thigh, and ask them to straighten their leg out. As long as they can get full extension, then they do not have an extensor lag. Passive testing for the range of movements. Again, just check for any hyperextension. Hyperextension can be judged by seeing how far the heel will lift off the bed, and you can measure that in centimetres if you need to be that accurate with it. With flexion, again, get you to bend your knee. And passively, we're just going to see if it goes any further, but do tell me if I cause you any pain, Uzo. Is that okay? So you can't go much further than that, so his passive flexion isn't any more than his active flexion. So we've done our look, feel, move. The other thing you can do is, as you're bending the knee, is just feeling for any crepitus within the joint, particularly in the patellofemoral joints. Just feeling if there's any sort of crackling feeling as you're bending and straightening it. So going on to special tests, I'm going to do a ligament examination. So first of all, the collateral ligaments. And what we're doing is just putting a valgus stress on the knee. So you have to bend the knee slightly, and you have it around 20 to 30 degrees of flexion. And what I'm doing is applying a valgus stress against the heel of my hand and seeing how much it opens out. Make sure again you're asking the patient if I'm causing them any pain. The lateral collateral, you can swap hands now and apply a varus force, and again you're seeing how much he's opening out, and he's got a nice firm end point there, so his collateral ligaments are intact. You have to flex the knee to around 20 degrees to relax the posterior capsule, or they won't open up at all. Cruciate ligaments, well, we flex the knee up to 90 degrees on both sides. Bend this one up as well, and I look from the sides and I'm seeing if he's got any posterior sag, just to see if there's any PCL injury. Just see if the tibia will fall back. Then we can test for the ACL. And the first one is the anterior draw. And what we're doing is having the knees flexed to 90 degrees. I'm going to put my hands behind the knee. And just as you're pushing up, you're just feeling to make sure his hamstrings aren't tight and not contracting. My thumbs are over the front of the knee, over the tibia, and I'm applying a forward force just to see how much he'll shift. And he's not moving much at all, so he's got a nice tight ACL. Always compare to the other side, and you're just stabilising the foot with your bottom. You don't have to sit on the foot, and you always make sure that they haven't got any problems in their feet before you stabilise them. Making sure there's not an anterior draw. Lachman tests. A lot of medical students struggle with the Lachman test. But it's something that is important. If you've got a partial ACL injury, it's important to be able to do that as well. So you're bending the knee up to about 30, having it nice and relaxed. You're stabilising the femur with one hand and holding the tibia with the other. And again, you're just moving the tibia forward on the femur. And you see Uzo's got a little bit of laxity, but a firm end point. I've got quite large hands, so it's a lot easier for me to do this test, but some individuals find it easier just to rest it over your knee, stabilise the femur with one hand and pull the tibia forward with the other. And that can be an easier way of doing it. So that should test for any instability within the knee. So we've done look, feel, move. The last thing we can look at is Uzo's patellofemoral joint specifically. And we can look for any apprehension testing. So we can pull the kneecap across and see if that causes any anxiety. And we can also look at the patellar tracking. We look at the overall alignment, make sure the kneecap's sat centrally, and look at its attachment on the tuberosity. Can I get you to sit over the edge for me, please, Uzo? We're getting Uzo in a sitting position now, and what we're going to do is have a look to see what his patellar tracking is like. So can I get you to bend and straighten your knees both at the same time for me, and bend them. And we're seeing if the kneecaps are sat centrally in the groove. Keep going. And you can see Uzo's kneecaps are running well in the groove. There's no lateral tracking. There's something called a positive J sign, which as they extend the knee, the patella comes out this way and then clunks back, and that's what a J sign is. But Uzo's patellar tracking seems quite central. And that concludes our examination today.